Right, uniportal VATS thymectomy for large thymoma. We have a 28 years old lady with recent diagnosis of myasthenia gravis coming from a crisis where she was mechanically ventilated, and during this she had her CT scan which showed a large thymus. There was a lower loop pneumonia. Her acetylcholinesterase antibody were positive, and she had a plasmapheresis before weaning from the ventilator and be able to sit for a thymectomy. We plan to do a uniportal VATS thymectomy for her, and with introduction of the camera we can see that it is not just a large thymus, but it is a large thymoma. The problem with large thymoma is that it sometimes will be troublesome to have a space to work in. With this large thymoma, so we try to open the mediastinal pleura circumferentially around the thymoma using an energy sealing device ligature to dissect, especially near to the phrenic nerves, and also we use a hook diathermy when we need more angulation. Gentle dissection between the thymoma and the superior vena cava. Taking care not to go very deep without proper visualization, not to injure the innominate vein. We try to go back and forth. We lift the pericardial fat till the end, try to get the whole thymus. Going to the left side from the left inferior horn upwards until reaching to the superior horn, and again making sure that there is a well control and visualization of the innominate vein and the internal mammary vessels at that stage. Here for the right superior horn, it is a little difficult as the thymoma extend in this horn upward, so we try to make gentle traction, control small vessels, and here you can see the inferior surface of the horn. We sometimes open the capsule over it so it can be easily swept from the lower neck. Now you can see that we open the capsule, making sure it's away from the innominate vein that you can see just beneath it. And again we try to be careful at that level not to injure the innominate artery, which is situated between the two superior horns. We switch back to the left superior horn. It comes more easy as it is not enlarged like the right one. And then back to the right one again. Lung dissection with gentle traction and the use of the ligature. Still we have some parts from the capsule. We take it. And back to the left superior horn with some traction and use of energy sealing. We can now deliver the left superior horn by some gentle traction with the help of a diathermy. It is important to have a good vision while doing this traction, and if there is any feeding vessel at the top of the horn, it should be coagulated, like you see here. Now this is the left superior horn is completely delivered. So we are now ending up to see the right superior horn from the left hand side. We use the snake head to do some dissection, and then we go back and forth until we see the twigs going from the thymus to the innominate vein. Now we can deliver the right superior horn. We calculate the tip, and we are lifted up with the feeding twigs to the innominate vein. We usually put a hemo clip for this one. Sometimes it is more than just one. There are some small bleeding. We use coagulation to divide, and we put a sponge on a stick on the small bleeder for 10 minutes, and it is stopped spontaneously with compression. We also make some coagulation to make sure that there is no bleeding. You can see the stump here, and now we will take the thymus out. We realize that we have the complete 4 horns, and then we go inside again and we remove the remaining pericardial fat. We check for the last time the hemostasis, make irrigation with warm saline. In this case, we did not open the left pleura, as the main bulk of the thymus and thymoma was on the right side. We asked the anesthetist to inflate the lung, and we put small catheter, drain all the air, and patient was coming out without chest tube.